operating surgeon is Dr. Sri Ganesh. Sir will be operating on a 59-year-old female, left eye. Patient doesn't have any systemic illness. The grading of cataract is NO3 to 4 with cortical cataract, and plus 20 diopter Hoya geometric lens will be implanted.
Good morning, everybody, and welcome to the OR. No, you should have asked first. But your rexus was like a femtorexis, so congratulations on that. Okay, so now we are starting. This is a 59-year-old. You can see a patient with like a grade 3+ cataract. The femtorexis is already done. I like to do the femtorexis because you get a perfect capsulorhexis and a nice 360-degree overlap. This is a 5 mm rexis, and we are going to use a 20 diopter Hoya geometric plus. This is the left eye of the patient, so we are using a geometric plus. So I like to make the side port with a 1 mm diamond blade. I use this to stabilize the eye, and this is a 2.3 or 2.4 mm keratome, and it's like triplanar. I go in, dip down, again raise slightly so that I don't get a chevron incision. You get a nice like squarish incision, and then you can see the rexus is already done. I put in visco, and then I depress in the center. That releases the sides. Okay, you can see the sides are released, and as you push in and just it creates a vacuum, and then you can just pull out the rexus. So I don't use a forceps. So my principle is economy of movements. This is the hydrodissection. Go with the hydrocannula underneath, and you see the posterior fluid wave. You see the nucleus rising and decompress, and with the cannula it freely rotates. See? So you just need to do that one step, hydrodissection, and then you put in viscoelastic, and I'm using the Quatera, and with parameters of 700 vacuum in vacuum mode. That means like it acts like a Venturi pump, and this is the new tip for the Quatera. It's a 45-degree bent tip, like the Kelman tip. Goes in through a 2.2 mm incision. Light nodi, sir. Light and water. I'm using a 1.25 sharp chopper. I'm going to do a direct chop. So you start at the edge of the rexis. I'm using the APM quad here. Bury sufficiently, then hold the vacuum and bring the tip towards the center. It's a denser cataract, you can see. You can do sequential burying, and then you have to split the nucleus. You can see I'm at the peak of vacuum. If you can see, it's 629 vacuum. Because Bangalore has a higher altitude, it doesn't go to 700 vacuum even if you set it. Because we all know that vacuum depends upon the atmospheric pressure and altitude. Rotate, again bury, chop. Okay, and then I just have one parameter. Bring it to the safe zone, which is the center. And you can see that the followability is excellent, chamber stability is excellent. I've removed one quadrant. This is the second quadrant again. You'll have to separate the piece fully. If it's attached, it will not come up to the center. Then again you can chop it into smaller pieces, and you can see that the followability is quite good. You can go full on the vacuum, press down on the foot pedal, adequate phaco energy. APM is advanced pulse modulation. So it is a pulse modulation to improve followability and efficiency. So this is again, you can see the last piece also. I don't actually reduce the vacuum. And you can see that the chamber is extremely stable. That's the last piece. Sometimes there's a small piece sticking at the side port. You need to kind of just push that. And you can see that. I like to use a coaxial IA because it's more efficient. Just a minute, visco. You can see that sometimes the small fragments which basically see, if there is a small fragment and you go in with your IA, then you will not be able to remove it. So you have to check, and then I like to kind of use the phaco for removing that. Then I use a coaxial IA. I like the coaxial IA because it's more efficient. You can go to higher vacuums. Again, vacuum is around nearly 700 here, and I do the hurricane technique where I go 360 degrees around. Quiet please. That's the subincisional cortex. Most people have difficulty removing the subincisional cortex, but if your flow rate is high enough, then the followability is good, and you can remove the subincisional cortex. You can see still there is visco there. I like to do a little bit of hydro polish to kind of clean the posterior capsule. Okay. Now if your incision is perfect, as you hydrate the side port, you can see that the pressure is maintained, the AC is formed very well. Okay. And this is the Hoya geometric plus, which has a differential light distribution. The geometric has more light distribution for distance. Geometric plus has more light distribution for reading. This is the best in class injector from Hoya. It's called the multi-cert. You put in viscoelastic, fill the viscoelastic there, and then after that there is a block here which you just lift off, and then you just push this plunger forward and lift it off the case. And like Dr. Ramurthy said, you can either use the screw type or the plunger. Here I'm going to use the plunger. You can see that it's nicely folded the lens in the cartridge, and you can either use a wound assisted or in the wound injection. If you want to use a wound assisted, you just pull this guard forward. Okay. So what I'm going to do is, what I'm showing you is insertion under BSS, because I don't use an irrigating cannula, and I just form the AC with BSS. You can see I form the AC with BSS. I just go in through the wound and inject it, light and notary, into the capsular bag. Okay. It opens up smoothly. Then I just go in with my coaxial and just nudge it into the bag, and there it is. You can see that it's beautifully centered. The lens opens up very quickly, unlike some of the other lenses which takes a long time. The unfolding time is quite good, so you don't waste time. And it's very important for torics, because if the lens does not unfold fully before you finish the surgery, you can have rotation and misalignment. And also the other nice aspect is that the haptics do not stick to the optic. So I just put off irrigation and then come out.
Don't you think that if the wound were released with leaky also, this just using BSS alone and not using an infusion?
See, I don't even have to
shallow
hydrate the wound. You can see it's well formed. But I will just show you how the wound is. See, it is quite tight. You can see that the lens is beautifully centered with a 360-degree overlap. I just hydrate the sides. The other thing you can do is you can hydrate the bed. This is okay, and that closes the wound. And you can see it is so tight. Okay, light kansata moonlight. You can see the Purkinje images. Light nodi moonlight. Kannallasbadi. Light nodi. You can see that the Purkinje images are exactly in the center of the optic. So it's a 3.2 mm diffractive zone. And you can see it's beautifully centered. This is very important. And now we will look at the OCT, and then that will kind of clarify Dr. Chitra's query about the wound.
No, I wasn't questioning your wound.
No, I'm just showing you. See, I created it like a triplanar with the blade. So you can see that is a wound. You can see the OCT there. You can see the wound. There is no gape. Even the internal lip is perfectly sealed. So even if you stand on this eye, it's not going to open. Okay, and since I have not used bimanual IA, the side ports are not stretched. So you can see that it's perfectly centered. The wound is very stable. The AC is well formed. So that's the end of the surgery. Thank you very much, dear friends.
Thank
you. Any questions?
I think all the questions to be asked was answered by you. So very well done surgery.
Thank you, Chitra.
Thank you, sir. Watching Dr. Sri Ganesh operate is always a treat.